It's going to be a short talk. We're just going to discuss a bit on fluids, um, and see how far we get. If we need to go deeper into the whole theory, then yeah, if there is time. So fluid therapy. Fluid therapy is something that we do almost daily in our practice. And I think the biggest question we ask when a patient comes in, whether it's an adult or child, is what fluid should I prescribe? Um, and sometimes we're governed by what our previous practice or what our seniors actually um, prescribe, and that is what determines what we're going to prescribe next. But the whole talk is to try and get you to individualize your management and to think for yourself before you prescribe any fluid to a patient. And as you can see, the patients we deal with on a daily basis are quite vast, from a newborn to the seniors. And total body water in each uh, different patient is totally different. From a newborn with about 80% total body water to a senior who has got about 50 to 55%. There's also differences in total body water between male and female. So the other thing we need to consider is why are we giving the fluid? Is it to resuscitate the plasma volume, the interstitial volume, or is it for intercellular purposes? And each compartment has got different concentrations of electrolytes and protein, and that determines what we're actually going to give. So, in a nutshell, all this is what we call fluid stewardship. And when you're in front of a patient, you need to ask yourself, what fluid, just like you ask yourself what antibiotic is safe for the patient or what medication is safe for the patient, you need to ask yourself, what's the right fluid for this patient? Is this fluid for the right patient? Is this the right drug to give this patient? Which is the fluid? Are we giving it in the right route, and is it the right dose? And always remember the pillars of fluid stewardship, which means, is it the right fluid, which is the drug, uh, the right dose, the duration of giving your fluid, and always de-escalate uh, during the whole process of resuscitation, optimization, stabilization. Malbrin is the one who came up with this idea that fluids are drugs. And so why do we say fluids are drugs? It's because we can define fluids into different classes, just like antibiotics. Are they hypertonic, hypotonic fluids, or isotonic fluids? And there's an indication for each different type of fluid. There's also a dose that you give per fluid. And each fluid has got different pharmacokinetics, pharmacodynamics, and toxicities. There's also a duration and de-escalation phase of each fluid. So every time we grab a bag of fluid from the drawer to prescribe to a patient, we need to remember that hypovolemia is bad, but hypervolemia is actually worse for the patient. So we always want to maintain a patient in this normal volemic state, and that is our Goldilocks, as they say, the Goldilocks state of fluid. Because hypovolemia results in poor perfusion of organs, whereas hypervolemia will result in edema and lots of problems with complications of edema. Right. So, looking broadly, the types of fluids that we come across in our daily practice, we classify fluids, of course, into crystalloids, colloids, and other fluids. And I think most of us are familiar with this classification. And our fluids are classified into your isotonic fluids, your balanced fluids, and your hypotonic fluids. And there's been a lot of talk on balanced fluids. So balanced solutions are fluids which are close to the same tonicity as plasma. They seem to be more friendly than normal saline. Remember, your normal saline is made up of a lot of sodium and as well as a lot of chloride, 154 millimoles of sodium and 154 moles of chloride. And we can talk further on what they call the strong iron theory, why normal saline will result in a normal anion gap metabolic acidosis, and that's why normal saline is sort of discouraged now for your resuscitation. And we were erring on using more balanced solution in resuscitation, such as ringers and your plasma-lyte or your balsol. So your choice of fluid is determined by the osmolality of the fluid, the electrolyte concentration of the fluid, and the buffers that are in that fluid, right? So osmolality is the total number of osmoles per unit volume. But osmolality counts both the permeable and non-permeable ions in the constituents of the fluid. And so you notice that, unfortunately, I don't have 10%. If you got 10% dextrose or 10% dextrose, if you were to actually look at the osmolality will be close to 300. But because your dextrose is actually an osmo, but it does not stay within the intravascular space. So it's not osmotically active. So when we talk about osmotically active molecules within a fluid, we now refer this to what's called tonicity. So tonicity accounts for the number of non-permeable osmotically active molecules, and that determines the ability of a fluid to remain in the intravascular space. And that is why when you look at things like normal saline, they're hypertonic because they've got lots of osmotically active particles, which then help the fluid stay within the intravascular space. So it's worth noting that each time you grab a bag of fluids, the question is, what do you actually want to do with that bag of fluid, right? Are you using it for resuscitation? Are you going to use it for maintenance? Are you using the fluid for replacement of ongoing losses, or is it for nutrition like your TPN? And what determines how you decide is, do you have the clinical signs that you need fluid, like dehydration or shock? Are your hemodynamics the indication for you to give a fluid, or are you using certain parameters to actually decide what fluid to give? Now, this diagram sort of summarizes in a 70 kg man, a male patient, for each different type of fluid, where does the fluid end up? And this is determined by your tonicity or your osmotically active particles within a fluid, as well as things like protein. So you notice that your colloid, almost 100% of it remains in your intravascular space. So if you need something to resuscitate your intravascular space, your colloid, and when I talk about colloids here, I'm talking about blood, because we've moved away from using your synthetic colloids, because your synthetic colloids are so please mute. Okay. Your synthetic colloids are associated with high rates of acute kidney injuries. That has now resulted in them being shelved from regular use. So when I talk about colloids, I'm mainly talking about blood products. If you look at your balanced crystalloids, about 20% will remain in your intravascular space, and the rest will seep into the interstitial space. And this is almost similar to your normal saline. And if you move further down the line, glucose, most of it will very little of it remains in the intravascular space. Most of it will move on into your intercellular space. Actually, your glucose will be broken down, and your free water then seeps into your interstitial space. So you can't really use your 5% dextrose as an intravascular resuscitation fluid. So you notice your hypotonic fluids, only 10% or less remains in the intravascular space versus your crystalloids, about 25%, and your colloids. So it's very important to remember this. Hahn and his colleagues looked at the pharmacology of fluids, and they looked at the different type of fluids that you use and how that affects your plasma expansion versus your patient condition and the rate of infusions. And it's interesting to note, you see in the first diagram, it shows that the sicker your patient, or the more hungry your intravascular space, the more responsive it is to the fluid that you give. So they gave them the same volume of fluid, but you notice with your hypovolemic shock patients, there was a better plasma expansion to your patients who were just normal anesthesia patients, or just your conscious volunteers. So your patient's underlying condition determines your response to fluid. The other thing is the type of fluid. This we've spoken about, your colloids versus your crystalloids versus your hypotonic fluids. But what's also important is the rate of infusion that you give during resuscitation. That's your fluid bolus. You notice the red graph, they infused over 30 minutes and they got a greater increase in your plasma volume versus infusing over 1 hour and infusing over 180 mils. So this gives us a picture why your surviving sepsis guidelines tells you to give a fast fluid bolus to increase your intravascular space, or for fluid resuscitation. Now, we talk about fluid resuscitation, but there are different phases of fluid therapy that one goes through when they are managing a patient from the emergency unit. And these steps in fluid management include the rescue phase, which is when a patient comes in, they're severely shocked and dehydrated. They need a rapid bolus. That's the rescue. So then optimization as well as stabilization. So optimization, after you've resuscitated your patient, you want to maintain tissue perfusion. And then you want to stabilize, which means just to support your organs and remain at zero negative balance. And then later on, de-escalate. And this gives us what we call the ROSE concept. And the whole Fluid Academy came up with this ROSE concept. And the ROSE concept stands for your resuscitation, optimization, stabilization, and evacuation phase. So your ROSE concept is a concept in septic shock where you get 4 phases of resuscitation, and each phase is associated with 4 hits, which means 4 adverse events that can occur during each phase of fluid management. So resuscitation is the rescue phase, and this is now when you usually when your patient first presents. And so when the patient presents, they're in life-threatening shock. They've got perfusion, they are vasodilated, their blood
now.
Their microcirculation is bad. And so we want to resuscitate. And there are different methods of resuscitation. And I think most of us have read about the surviving sepsis guidelines. The surviving sepsis guidelines are based on the end goal directed therapy. which was by Rivers. And this is where the guideline tells you the volume to give, right? So survivor safety guide says give 30 to 60 mils per kg, or they say 10 mil aliquots, and you reassess. Um, and it was found that this tends to overestimate the requirements of the patient. And so people, different groups came up with different trials, the process, the arise, and the promise trial. The process and the arise and promise trials, which were different groups, compared the rivers, which was a goal-directed therapy, to individualized care. And they then favored using more individualized care, which means you actually give a bolus, you reassess, and you decide whether you need to escalate your fluid management. Um, and this is what sort of is advised. But your surviving sepsis guideline is a guideline, and it's important to know that it gives you a guide as to what to how to manage your patient. Um, but it's always important to know that each patient is an individual, and they've got different fluid requirements based on why they are presenting to you. The fifth trial also came up later, and the fifth trial was a trial which was done in sub-Saharan Africa, in a place with low resources and very few ICU beds, and they were trying to tailor management to prevent complications from fluid therapy in these patients. And they found giving passive fluid boluses actually detrimental outcomes um, to patients, and they then advise giving smaller and with more ICU available to actually give infusions rather, or maintenance fluid. Uh, so how do you assess fluid responsiveness? As they say, each patient is an individual and you actually need to individualize therapy. So uh, before we go into that, it's important to know the definitions of the fluid therapy. So what's a fluid bolus? Fluid bolus is a rapid infusion of fluid to correct hypotension, whereas a fluid challenge is a test you do to actually check for fluid responsiveness. And different types of fluid challenges. And now we talk about a mini fluid challenge where you give about 100 to 150 mils over 5 to 10 minutes, and that's not enough. I think all of us know what fluid infusion is, and fluid overload is accumulative fluid balance of more than 10% of body weight. Right. So how do we assess fluid responsiveness in our patients on a daily basis, or when we're during fluid therapy? So there are different methods of assessing fluid responsiveness. Uh, and we can use the passive leg raise test, or we can use a fluid challenge. And you can see each one is different. With a passive leg raise test, it involves the patient lying at 45 degrees initially, the head then being brought down to lie flat, and then the legs are raised to 45 degrees. And depending on the parameter you're using to check your fluid responsiveness, you do that test after about 45 to 60 seconds after raising the legs. And a 10% increase in stroke volume is a positive fluid responsive test. And most of us are used to a fluid challenge where you actually give fluids or over 5 to 10 minutes, and then you look at your parameters and see if there is a fluid response. And to check for fluid responsiveness or to assess, you've got static parameters as well as dynamic parameters. Your static parameters are what you see, your blood pressure, your heart rate. You notice with a shocked patient, most shocked patients come in tachycardic, blood pressures are low, they've got no urine output, you do a blood gas, their lactates are high, and then you give them fluid and see if you get an improvement in your static parameters. But your static parameters are not as reliable as your dynamic parameters, because your dynamic parameters are things that are happening as you actually give the fluid. And your dynamic parameters include your passive leg raise test, your pulse pressure variation, and if you're able to do an echo, you can actually assess your IVC. Your dynamic tests tell you a lot about your cardiopulmonary interactions and also your stroke volume. So fluid responsiveness and fluid boluses during resuscitation tell you what the Frank-Starling relationship is what determines whether you get fluid responsiveness. And depending whether your patient is on the steep end of your Frank-Starling curve, you get a better response than at the flat part of your Frank-Starling curve. And so it's quite important to get used to using a certain parameter during your resuscitation phase, so you can reliably tell whether your patient is benefiting from the fluid that you're giving, or you're actually overshooting during resuscitation. But a key note is to remember that early administration of vasopressors is important, especially once you've given 30 mils per kg per bolus, because that actually optimizes, limits the amount of fluid that you give a patient. Now that you're out of the resuscitation, you've managed to resuscitate your patient and get organ perfusion. You want to stabilize and optimize and support their organs. But during optimization and stabilization, you need to be aware that that's when the second hit occurs. And the second hit occurs because after a period of ischemia, you're now going into a period of reperfusion. And you get reperfusion injury, and that's where you also get all your inflammatory your inflammatory reactions that are occurring. So during this process, you want to focus on organ rescue and to maintain tissue perfusion and maintain a neutral fluid balance. And there are different tests that you can do during this phase, such as looking at extravascular lung water. And you can do this by doing lung ultrasound. Of course, we might not all have access to lung ultrasound. Doing in terms of maintenance fluid, and it's important to know that during the maintenance phase, you're giving water, glucose, and electrolytes, and these should be part of your daily basal requirements. And you also need the dietitian to then help you with your nutrition. But in terms of maintenance fluids, most of us know about the holiday saga equation, which is your 4-2-1 rule. Or in other places, we say 100 mils per kg for the first 10, and then 50 and 20. And that comes from the Holiday Saga equation. And unfortunately, this equation was developed like in 1957, and it's almost like a thumbs up. It was derived in well patients, so it overestimated the caloric requirements. It also overestimated urine. So because of that, in ill patients, these are patients who are not mobile. Some of them are on ventilation. Some are getting humidified air. You can tell that based on that, their fluid losses are much less. Their caloric requirements are much less. And by using this equation, we tend to overestimate the patient's daily requirement, and this can lead to fluid overload. We tend to then in ICU calculate. We haven't discarded the equation because that's all that we have. But we tend to then use the calculation and either give 60 to 80% of their maintenance, but then balance it with what we're looking at the hemodynamics. We can do other things to look at. I keep talking about fluid overload. Fluid overload has got lots of complications, and with us pediatricians, we go from head to toe, and your complications can be like cerebral edema, pulmonary edema. It results in circulatory overload with its complications. It results in renal interstitial edema, and a big thing is abdominal compartment syndrome as well, and decreased absorption of your nutrients because you get bowel edema, and there's lots more complications that occur with fluid overload. And that is why it's important to have fluid stewardship. And you notice from different studies, I've just put one up here, which was done and this one is 2018 by this group. And they showed that if you look at this, almost 40% of fluid that a patient receives, you can see that's medication, flushes, oral fluids. They are all unaccounted for in your total and your boluses. They're unaccounted for in your daily calculation. And this is fluid creep. And it's very important for you to be aware that every time you approach your patient on a daily basis, you need to assess the fluid balance. And not only assess the fluid balance, but you should know that there's a hidden fluid that's
but it's not compulsory.
That is unaccounted for, and your patient is at risk of developing edema. Now, because of the complication of fluid overload, the fourth phase of the Rose evacuation or removal, deresuscitate, your persistence of a positive fluid balance results in high mortality. You can remember from the first few slides, there's a U-shaped graph in terms of mortality. Those who are hypovolemic are at risk of higher mortalities because of perfusion, and those on the other end are at risk of mortality because of fluid overload. So it's very important to always de-resuscitate a patient after resuscitation. We were always very good at resuscitating our patients. 10 mils per kg, 30 mils per kg, we give inotropes, but we always forget that we always have to de-resuscitate when the patient has been stabilized and optimized. And during this resuscitation phase, one should also be aware of the third and the fourth hit. And these happen when you've got persistence of your systemic inflammatory response, and your capillaries are still very permeable, and you're losing fluid into the interstitium and dead spacing. And in this case, some people advocate use of albumin for your glycocalyx. I'm not sure how many of you are familiar with the glycocalyx. And your glycocalyx is this layer of different uh, uh, different lipids which line the endothelium, and it's very important in that it's composed of albumin and different glycoproteins, and it's there to protect the endothelium, and it's actually there to assist with the absorption, or it determines what your interstitial space. And it's actually some also say it's there to prevent the red blood cells adhering from your endothelium. So it has got lots of different functions. And destruction of the glycocalyx during sepsis and infection results in increased permeability and a leaky glycocalyx, which means it results in interstitial edema, as well as leaking of protein. And that also affects your different oncotic gradients between your endothelium, resulting in what they call the revised Starling principle. Remember, there's a different Starling principle which involves your oncotic pressures and interstitial hydrostatic pressures, though. So it's important in your de-resuscitation that you're aware of that. And we usually use diuretics and dialysis during de-resuscitation, either an infusion of Lasix, boluses of Lasix, or you can use renal replacement therapy if available. So now, after we've gone through the whole process of resuscitation, stabilization, optimization, evacuation, to summarize, what you actually need to know is you've decided when to start your fluid, you've given, you always need to know when to stop your fluid. And you need to know when to start a fluid removal. That's your evacuation. And you need to remember when to stop removing fluid, because you want to avoid the last hit, which is your hypoperfusion, because you've over resuscitated your patient. This just summarizes what you're actually doing in each phase of the rows. Yeah, resuscitation is life-saving. Your optimization is organ rescue, and evacuation, you're removing toxic fluid from your patient. Right? And remember, with each phase during resuscitation, you want to maintain a positive fluid balance because you're rescuing organs. During optimization, it's slightly positive, but you need to actually get to zero fluid balance. And then during evacuation, you want to maintain a negative fluid balance. And you need a good record keeping of urine output, of either your patient's weight. You need to have a way of monitoring the fluid that you're giving and the fluid that's getting out of the patient, and what your fluid balance is on a daily basis. Sometimes not even on a daily basis, but hourly basis, if you've got a critically ill patient. So to summarize everything that we've spoken about briefly in this talk, remember we said fluids are drugs, and therefore, as any drug, you need to know the type of fluid you're giving, which means the drug that you're giving. Are you giving a crystalloid? Are you giving a balanced solution? Are you giving a normal saline? Are you giving a hypotonic fluid? What dose are you giving? How much fluid are you giving? And what method are you actually using to calculate that fluid, the duration that you're giving the fluid for, and your de-escalation. And always keep in mind what indication the fluid therapy is for. Is it for resuscitation, maintenance, replacement, or is it for nutrition? And you always need to ask yourself the 4 questions: when to start fluid, when to stop it, when to remove, and when to stop removing. And remember the 4 phases of fluid management, which is your resuscitation, optimization, stabilization, evacuation. Thank you.